Thank you very much. And thank you to the organizers for this really kind invitation. It's an honor to participate in this really interesting workshop. As you just heard, I'm a cardiologist, so I'm a little bit out of my element, but I expect really difficult questions. So here are my disclosures. Nothing relevant to this other than a clinical trial that I ran, which was not funded by industry. I'll start by acknowledging the folks who've done a lot of work, especially our patients, my team at the NIH, our collaborators, including those at the University of Michigan, where I was before I went to the NIH, and our funding sources. So I was asked to speak about coagulopathy in COVID, and so I thought it might be helpful to start with some simple definitions of how I think about thromboinflammation and coagulopathy. So thrombosis is a term that refers to local coagulation, which is the activation of an enzymatic cascade of processing of plasma proteins that ends up in producing fibrin, which is insoluble. That then becomes a hemostatic plug, or can become a thrombus within the vasculature itself. And this was the dogma about thrombosis for a few hundred years. And then more recently, in the last 10 to 15 years, we've started to think about thromboinflammation. This is a fairly complex intersection of inflammatory and coagulation networks that then leads to thrombosis. This has been becoming more of a central dogma in how we think about thrombosis in the clinical setting today. And we've been studying this for a few years, and I started to link together a few years ago, as Dr. Lieberman mentioned, the inflammasome activation. We linked IL-1 beta inflammasome activation as this central mediator that bridges inflammation and coagulation in venous thrombosis. Certainly we were thinking a lot about this in COVID as well. We were in talks with a company to start an IL-1 and anakinra trial, and then the pandemic hit and we had to stop the venous thrombosis studies. So I'll tell you again, as a cardiologist, I have to keep things somewhat simple. And so I'll show you a cartoon of how I think about thrombosis and thromboinflammation. You all know what the endothelium looks like, and when it's quiescent, it's everything is copacetic. But when there's some sort of an injurious stimulus to the endothelium, it starts to release cytokines. It starts to produce coagulation factors and cell adhesion molecules at its surface. You also have platelets that can then start to become activated. They release their own biorepository of molecules. They can bind to the endothelium. They start to aggregate and clump together, which can then occlude the vasculature. We also have inflammatory cells or immune cells like monocytes that release cytokines, a whole bunch of other procoagulant molecules, including tissue factor, which can initiate the coagulation cascade. And then you have neutrophils, which do a number of things. They certainly bind to the endothelium. They can bind to platelets. They release reactive oxygen species, and then through a process called netosis, which I'll share with you more about later, they can extrude their DNA and start to form the scaffold for a thrombus that forms in the vasculature. So at the start of the pandemic, we learned a few things. Patients who had COVID and were hospitalized certainly had a few different sets of symptoms, mostly a lot of respiratory dysfunction. We knew that they were characterized by lymphopenia, and a subset of these patients would have a stable period, followed by which around day 7 to 9, they would start to decompensate and find themselves in an ICU, and we attributed this to cytokine storm. About a quarter of the patients who were admitted with COVID would end up with organ failure. And once you were in the ICU, half of those patients would not make it out of the ICU. So about 25% of patients admitted to the hospital in the early stages of the pandemic would not leave. And the prevailing hypothesis at the time in the scientific community was that alveolar cells and alveolar cells and monocytes were starting to really drive this inflammatory cascade in these patients that was resulting in organ failure. And so we'd been thinking a bit about this since I was a fellow during the H1N1 epidemic a decade ago, and I remember rounding on patients who were hospitalized with H1N1 and realizing that they had a lot of thrombosis, and so we'd anticoagulate those patients and get them off the ventilator sooner. And so when COVID started, I asked myself in March 2020, why aren't we seeing more blood clots? And sure enough, that the reports started to follow. We saw reports about sticky blood, where IVs and tubes were clotting constantly. There's also this coronavirus blood clotting mystery that started to intensify. And then we saw autopsy series like this one from New Orleans, which demonstrated diffuse thrombosis in microangiopathy across venous beds, arterial beds, small vessels, and large vessels. And so we started to think more about what might be driving some of this inflammatory and thrombotic signaling. And so the themes we'll cover today are endothelial injury and platelet hyperactivation. I'll talk to you about my favorite topics, neutrophil extracellular traps and autoantibodies, and then we'll wrap it up after that. And so we've heard a little bit about the endothelium already today. As you know, the resting endothelium, its function is to maintain homeostasis. It does this by acquiring an anticoagulant profile that is by expressing a number of different molecules on its cell surface. It also resists leukocyte interactions, and then it forms an intact barrier that reduces the amount of permeability to mitigate cell migration. And so early in the pandemic, a group from Yale found that patients who were hospitalized with COVID had high levels of circulating biomarkers of endothelial injury. And they called amongst this P-selectin, a cell adhesion molecule, increased activity of VWF, and increased soluble thrombomodulin, suggesting that the endothelial surface where thrombomodulin should be is now injured. We also heard that SARS-CoV-2 may alter the endothelium. Whether that's direct, it remains to be debated. Certainly this image suggested that there may be viral particles in the endothelium. I'm not a virologist, so I won't speculate on what that means. And this group in Germany with Stahl and colleagues were interested to understand why a lung infection might have systemic manifestations. And they did a very simple, but I think elegant experiment where they took healthy endothelial cells and treated them with either control serum or serum from patients with COVID. And what they found is that the COVID serum was able to completely denude the protective carbohydrates on the endothelial surface, suggesting that there's glycocalyx injury with denudation of the heparan sulfates. And so at this time, we were also interested in understanding what COVID serum might do to the endothelium. And so Hui Shi in our group is a postdoc who's now back in China. She designed an in-cell endothelial ELISA because she had to do these experiments under BSL-3 conditions. And so wearing hazmat suits all day was only so much she could tolerate. And so in this assay, she incubated healthy endothelial cells with serum from either control patients or those patients who were hospitalized with COVID, and then measured the expression of these cell adhesion molecules at the surface. What she found is quite interesting. Patients who were hospitalized with COVID, their serum was able to induce increased levels of cell adhesion molecules on the endothelium. And then more interestingly, those samples that induced the highest levels of cell adhesion molecule expression were the ones that we got from the patients who were sickest in the hospital. So those who had respiratory failure and were required mechanical ventilation. She also extended this further to see if this was functionally relevant and found that the higher amount of cell adhesion molecules certainly translated to more neutrophil adhesion to the endothelium. And so that's what you see here in the green dots on the right. And so at this point, we added all of this together and felt that there's some sort of a soluble factor that's injuring the endothelium. And this could be either viral particles, it could be some sort of an inflammatory mediator like a cytokine or a chemokine or other damage-associated molecule, or some other factor that we hadn't elucidated yet. And so we said, well, wait a little bit to learn more about this. Platelets also are hyperactive in COVID. There are several groups that have been studying this now over the last 2 years. This group from Massachusetts found that when platelets are exposed to SARS-CoV-2 virus, within minutes they start to release microparticles and exosomes, which carry their biologically active cargo to remote locations. We also know that platelets isolated from patients with COVID express a lot more P-selectin at their cell surface, which is an indicator of platelet activation. And certainly when you take these platelets and you add more agonists to them, more platelet activators to them, the ones from COVID patients were still much more activatable than those from healthy controls. And this p-selectin at the cell surface does more than just mark platelets that are active. It actually may facilitate platelet leukocyte crosstalk. And here you see very simple peripheral blood smears that suggest platelets interacting with neutrophils, monocytes, and lymphocytes. Although the exact nature of this communication is still unclear. So my favorite topic here is neutrophil extracellular traps. We were looking at reports of SARS-CoV-2 infection from China and noticed that in non-survivors, these patients were characterized by very low lymphocyte counts, yet they had normal amounts of total leukocytes, and we speculated that perhaps this difference could be neutrophils. And so we've been studying neutrophils for some time. Neutrophils, we know, are a fully armed side of the innate immune system. And when they encounter pathogens like bacteria, this audience knows very well that they can start to unravel their chromatin and release it in the form of extracellular DNA webs and tangles. And this is important to trap and then kill these bacterial pathogens. Now, what our group and many others have realized over the last 10 years is it does a lot more than that. And these neutrophil extracellular traps, or nets, are also capable, they also express a lot of let me rephrase that, a lot of prothrombotic and procoagulant molecules on their cell surface, and they can also serve as a scaffold for thrombus accretion inside the vasculature. And so we hypothesized that perhaps this makes a difference in COVID. And at the start of the pandemic in March, we started to rapidly collect samples. These were discarded serum samples from patients who were hospitalized with COVID. Clinical studies and research studies were essentially at a halt at this time. And we measured a number of circulating biomarkers of neutrophil extracellular traps, including this MPO DNA complex. And what we found is that neutrophils are certainly hyperactivated in patients who are hospitalized with COVID, and they had higher levels of this MPO DNA complex, suggesting there were more nets. Interestingly, when we look only at the patients who were hospitalized with COVID, we found that nets also tracked with the severity of COVID infection. And so those who were in respiratory failure had higher levels of nets on average than those patients who were stable from an oxygenation perspective. Ray Zhu was also interested in understanding whether this inflammation in circulation could actually lead to more net formation in that feed-forward loop that Dr. Lieberman mentioned. And so he took healthy neutrophils and incubated them with either healthy serum or COVID serum, and found that the COVID serum induced potent net formations, shown here in green on the right. And a number of groups across the world have validated this since then. I like this image from Utah on the bottom, which is a lung autopsy specimen, which shows platelets in red interacting very closely with netotic neutrophils, shown here in white. So we've been thinking a little bit about whether nets can be suppressed, and a number of clinical trials are ongoing to try and understand this. I think Jeff Stritch, who's in the audience, his clinical work in both phase 2 and phase 3 studies using fostamatinib, which is a spleen tyrosine kinase inhibitor, is probably the most promising candidate to have a clinical effect. So really excited to see what the phase 3 results will look like. We think that'll come in the next several months. So I'll skip this part on calprotectin. This is really just showing that we identified calprotectin as a prospective biomarker of respiratory failure in patients with COVID, and that led to a new assay that we've helped develop that now has a CE mark for use in Europe. The next part here is about autoantibodies, and I want to focus on this because it's come up in 3 of the 4 or 5 talks so far. At the onset of COVID, when we saw that patients were developing this diffuse coagulation, we drew similarities to another syndrome, one called antiphospholipid syndrome. And this is an autoimmune condition that's marked by macro and microvascular disease and thrombosis. And it's clinically identified by lab testing that shows the presence of antibodies that target phospholipids and phospholipid binding proteins. Now, this is a disease that's chronic in nature, often affects young women to start, and completely wrecks their bodies over time, where they develop a lot of cognitive dysfunction and other complications. So certainly a lot of relevance to other autoimmune conditions, and certainly some ties to long COVID here as well. And so as we were thinking about this, there were reports that started to come out about antiphospholipid antibodies in patients with COVID, including this report of 3 patients that show they had these antibodies, and they also had stroke. So we decided that we'd measure this in our patients. And I'll skip this part over here in the interest of time. We measured this in 172 patients that we had derived samples from. We looked at a whole panel of antiphospholipid antibodies and found that 50% of these patients remarkably had some elevation of at least one of these antiphospholipid antibodies. And so we hypothesized that perhaps these antiphospholipid antibodies, just like we see in this APS syndrome, were also activating neutrophils in patients with COVID and then leading to more NET formation. To test this, we purified whole IgG fractions from patients who were hospitalized. And in vitro assays, we treated healthy neutrophils with these IgG fractions and found that they certainly stimulated NET formation, which you see here in green on the right. But to understand its relevance in vivo, we switched over to use an animal model of venous thrombosis. And in this model, we injected mice with antibodies from either healthy control patients or those with a catastrophic thrombotic variant of antiphospholipid syndrome called APS, and measured the clot size. What you see here in blue is the healthy IgG. What you see on the right there in yellow is the catastrophic APS thrombosis. And when we injected mice with IgG fractions from patients with COVID, we found remarkably these clots were massive in size. And these are what you see on the right here in dots in red. And each of those groups is one patient. We did 6 of these 6 different patient-derived antibodies. And the clots were the largest in those patients who had high levels of antiphospholipid antibody titers. Here's a photomicrograph of what these clots look like with a scale bar next to it. You see the control, caps in the middle, and then the COVID antibodies on the right. So taken together, this suggested to us that there are autoantibodies in circulation in patients with severe COVID that are marked by antiphospholipid antibodies as an indicator of their thrombogenic profile. And these antibodies may actually be wrecking our immune systems and our vascular systems by having a functional effect and detrimental tissue injury. We also wanted to look to see whether our endothelial activation was also linked to this COVID IgG, and certainly found again using that same in-cell ELISA that IgG from the patients who were hospitalized increased endothelial cell adhesion molecule expression. And when we depleted that IgG, we were able to abrogate this endothelial activation phenotype. And then when we reconstituted healthy serum with the COVID IgG, we were able to recapitulate this phenotype here on the right as well. So the highlights here are that COVID disrupts many vascular and hematologic thromboinflammatory checkpoints. It induces the production of a broad repertoire of deleterious or rogue autoantibodies. Yet the full spectrum of these autoantigens is unknown, so I hope that Dr. Altman will help figure this out. The ideal strategy to target thromboinflammation in patients with COVID may involve using multiple therapeutic targets that help tune the immune responses as opposed to targeting only a single cytokine or pathway. And so we've launched a clinical trial that helps to help test this as well. The trial is closed, and I hope to report some of those results to you later. And then more importantly, as we think forward, I've heard a phrase from P.J. Utz at Stanford that we've got a once-in-a-lifetime opportunity to understand how autoimmune disease occurs and how we might be able to modulate these physiologic and pathologic phenotypes. And so I hope that we can look at vascular immunobiology as a lens to study thromboinflammation, not just in COVID, but in other disease states as well. So like everybody else in this room, we are looking for postdocs. So if someone's interested in some of this work, we're happy to chat with them. And then I'll stop here and be glad to take questions now or when the time is right. Thank you.
Thank you, Dr. Kanthi. We have time maybe just for one question, and then we'll please continue at the discussion time. Okay.
Yogen, that was a great talk. Could you just add some comments about your view of how you would weave complement activation, which is so intimately tied to microthrombosis and has been dysregulated in COVID-19, into this story?
Yeah, Lenny, it's a really great it's a great point, and I had several slides in there, but I removed those because I was already over on time. But I certainly think complement plays a central role in this process. We know that complement is certainly deranged in the lung, epithelium, and endothelium in patients with this disease. We also know that neutrophils, when they form nets, they can actually start to express and present complement at the surface, which can then lead to a cascade of signaling events that increase both thrombosis and inflammation. So certainly there's a lot of hope for what complement modulation might do in COVID. There have been clinical trials that have started to try and test test interventions, and there's been some really interesting results that have come out of it. I think it's a difficult study to do because, as we've heard, there's so much more going on in this disease that using one particular agent may actually may confound some of the interpretation of results because patients are heterogeneous. There is the possibility that using combination therapy complement may actually help augment some of the other interventions that we think about. But certainly, I think complement modulation becomes a central part in this disease. Thank you. It's a great question.